Okay, cheers. Right. Good morning, everybody. This talk is on epistaxis. Now, epistaxis is a Greek term which implies to drip. Now, as you know, that medicine is actually has got a dichotomous fashion. The Romans actually have got the anatomical terms alluded to them, and the Greeks have got the pathological terms. So epistaxis is a Greek derivative. Now, this presentation is in partial fulfillment of the acerbic requirements of the Caesar program, according to Boone's strict teaching program. Now, I chose epistaxis because epistaxis actually presents a conundrum in A&E. Years back, we used to have a proper ENT examination room in A&E, but what we now have got is now like a rudimentary structure, which masquerades as an eye room, or where you can actually go and see patients who are bleeding. But most of the patients we are having to just assess them if they've got nosebleeds in the cubicles where they are, and it's quite a huge challenge. Now, I've started with this slide, which is showing the blood supply of the nasal cavity. So you can see that the main vessels are the greater palatine artery, superior labial artery, and Kisselbach's plexus, which is like a confluence of those arterial ramifications, the anterior ethmoid, posterior ethmoid, sphenopalatine artery, greater palatine artery, and the superior labial artery. Now, if I move on to the next slide, I just want to remind us that the presentation is based on the curriculum fundamentals, which have got to do with the basic medical sciences. We've got to have knowledge of that, the epidemiology of epistaxis, differential diagnosis when we are working out what's the cause of epistaxis, the investigations that we do, and the management. Now, epidemiology of epistaxis is based on a number of factors. So, for example, 5 to 14% of children have got one episode per year of epistaxis, and epistaxis is rare in those under 2 years. 10% see the GP, 10% are seen by the age of 5, and between 6 and 10 years, up to 56% of kids present with epistaxis. Of those, 10% are referred to ENT. Now, most of the anterior bleed, the majority of the bleeds are from the anterior aspect of the nose, the area called Kisselbach's plexus or Little's area, where the percentage is 90%. Now, posterior bleeds from the Woodruff's plexus or posterior to the medial turbinates constitute 10%. And these actually mainly from the actual arterial bleeds from the sphenopalatine artery. Epistaxis as a bimodal distribution, it happens in mainly 2 to 10-year-olds. Then there's a gap, and then it will actually occur in midlife. Now, if you see epistaxis in teenagers and those who are in their 20s, you should suspect local factors like cocaine sniffing, or there could also be a traumatic element to it. Now, the blood supply of the head and neck is based on the carotid artery ramifications. Now, the carotid arteries are 2, and they are the external carotid and the internal carotid. Now, each of these arteries actually gives branches that actually supply the nasal cavity. So, for example, the sphenopalatine artery, which supplies the posterior part of the nasal cavity, is derived from the external carotid. Right now, and this supplies 90% of the nasal cavity, lateral nasal wall, the turbinates, and the posterior nasal wall. Now, the ophthalmic artery, which is derived from the internal carotid, supplies the anterior nasal septum. So you can see how there's overlap between the external and internal carotid arteries in terms of supplying the nose. And that also determines on the management aspect of some of the complicated bleeds, which I shall come to later on. So the anatomy of the turbinates, if you were doing head and neck anatomy, you would actually have learned that the inside of the nose has got what are known as mucosal folds that are known as turbinates. Now, turbinates have got two functions. They humidify the air, and they also moisturizing it when you're breathing in. Now, posterior to the inferior, middle, and superior turbinates, you've got the posterior nasal space. And that's the one where, if you are, say, for example, if you are doing the lateral flow test, you've got to get your sample from there. And or if we are putting a nasogastric tube, if you feel the give, as we are inserting the nasogastric tube through the nose, that is, you are now accessing the posterior nasal space. And so it's important that when you are doing an examination for epistaxis, that you look inside the nostrils, and then you also have to ask the patient to open their mouth so that you can look at the oropharynx, so that you can be able to see if there are any clots at the back of the mouth. Now, blood supply of the nose, like I said, that's in more detail now. Now, I just want you to take note of the association between three big vessels here: the greater palatine artery, the sphenopalatine artery, and the ethmoidal arteries. Now, there's an area that these vessels are actually coalesce, which we call the Kissel back plexus, because plexus is that area which is just like a confluence of those vessels. Now, that area is, in most situations, is the main source of the bleeding in the anterior aspect of the nose. So if we've got an anterior epistaxis, it's the Kissel-back plexus which is bleeding, or the litus area. So when you're doing the examination, you've got to look at that area, and if it is full of prominent vessels that are red, congested, that is most likely to be your source of bleeding. And in most situations, you've got to manage that epistaxis by dealing with the litus area. Now, I'm going to delve into the causes of epistaxis. I'll start with the local causes, and some of them are so simple, and some of them are to identify and also to avoid. Nose picking. Now, most cases of nose bleeding, particularly in kids or even in the older population, is due to nose picking. Something that appears like innocuous can actually culminate in torrential nosebleed. Dry mucosa, when the atmosphere is very dry during certain months like winter, or when the ambient atmosphere is not well humidified, you can actually cause dry mucosa, which can actually cause nosebleeds, particularly in the elderly population. And then trauma, we encounter this in A&E many times, with many people coming in after having been assaulted or having fallen, they've got a nosebleed. Drugs, snorting cocaine is noted to be a source of epistaxis. Now, then I'll move on to systemic causes. Liver disease, you know that the liver has got about 500 functions that it does. And one of them is to synthesize clotting factors. And so people with liver disease tend to have epistaxis. Hereditary telangiectasia, again, it's quite common to have that, epistaxis. Von Willebrand's disease, this is also associated with epistaxis. Alcoholism, then you've got also drugs, NSAIDs, factor 10 antagonists, apixaban and rivaroxaban. Then you also have got warfarin. I think warfarin, we know that it affects synthesis of clotting factors. So which are those ones? The acronym used to be 1972, factor 1, 9, 7, and 2, and 10, sorry. So warfarin is actually involved in this. Hypertension doesn't seem to cause epistaxis in itself, but when you actually measure the blood pressure of people actually coming through A&E, we've got who are coming with epistaxis, most of them would have elevated blood pressure, which we have also to deal with when you are treating that epistaxis. This is just a pictorial demonstration of causes of differential causes of epistaxis. Now, coming to history and assessment. When you're taking a focused history about epistaxis, you need to ask about the nose picking, obvious triggers, and you also have to ask the patient whether they are bleeding from one or both nostrils. Why? Because anterior epistaxis, the one from the litus area or from the Kisselback plexus bleed, tends to be unilateral, whereas bleeding from the posterior aspect of the nasal cavity tends to come from both nostrils. And those who are bleeding from the posterior aspect of the nose tend to spit clots as well, tend to spit clots. You also have to ask about medical history and drug history, like I've alluded to earlier on. Then you assess the patient on ABC principles. It's very important for you to do first aid maneuvers. The HIEM learning side suggests that we sit the patient at 45 degrees and apply pressure for 10 minutes, after which you have to contemplate, packing the nose. Also assess the airway patency, and if there are any clots to be suctioned or any blood to be suctioned, you have to do that. Check for breathing saturations, blood pressure, pulse, color, and pallor of the patient. Investigations, you do full blood count, clotting, use and ease. You send a sample for group and save. You also have to do CT head for traumatic epistaxis. Now, in the management of epistaxis, I think you need to know in what order you're going to do your management. So for example, if you're in A&E and you've got the means to be able to cauterize the patient, you can actually do that and discharge the patient. So if the patient has got control over their lives rather than coming and they're all met with a decision to admit them. So if you can be able to cauterize them successfully and observe them over a period of 10 minutes or so, fair enough, they will be able to go home, and you discharge them with an Herceptin cream. Now, then if you're not able to cauterize the patient, there is a packing that we normally use, but I've not seen it in our A&E. But when I used to do ENT, we used to have some called nasal pore packing. Now, nasal pore packing is very useful, and I will tell you why. I was in Scunthorpe, and it was a gentleman who needed to attend a wedding, a family wedding, in 2 days of his granddaughter. And he came over there and he says, if there's anything that you could actually do about this epistaxis, is to allow me to go home today. Now, so I was faced with the option of either packing this guy with more robust packs, or I had to take the risk of using nasal pore packing. So I used nasal pore packing because it dissolves in the nose, and observing over 10 to 15 minutes, and the bleeding had stopped, and I sent him home with safety netting. And that was so nasal pore packing is actually ideal. But in DRI, nasal pore packing tends to be used by surgeons in theater when they've done septoplasty procedures and so forth. We don't have it in our department. What we have in our department is two main packs: mersal packing, which if you do it, you've got to admit the patient, and rapid rhino packing, after which you have got to admit the patient and refer them to ENT. Now, you also have got electrocauterization, but that is done in theater. And then there's another way of dealing with bleeds, which is sphenopalatine. Remember those blood vessels, sphenopalatine ligation, which has got a 90% success. You can also get the external carotid artery, and you can also get the internal maxillary artery. But all these are ENT and theater procedures. You can also embolize the sphenopalatine artery and internal maxillary arteries. Now, just these are pictorial demonstrations of silver nitrate cauterization. Now, these sticks they come in this kind of packaging that they look like matchsticks. Now, there was an incident in which I don't know what trust it was. It came through the HIEM learning site where these silver nitrate cauterization sticks were mixed with cotton, the cotton wool buds that have got stick ends, and which we normally use for eye examinations and so forth. So these were in the same drawer or locker, and the doctor actually they thought they were actually doing an eye examination, and they picked up silver nitrate sticks, and they put that thing in the eye, the silver nitrate stick in the eye, and just imagine the damage to the cornea that could have happened. So in our trust, we don't mix, eye equipment with nose examination equipment or treatment equipment. They should also be separate. Now, this picture I've got here shows how we do the silver nitrate cauterization. Look here. So this, the end of this stick, which has got the silver nitrate, is actually used to touch the bleeding point, which is actually in the litus area. Now, you are not supposed to cauterize. If you are cauterizing one nostril, don't do it on the other side, because you can cause septal perforation. So you're just supposed to touch lightly on one side and not do it on both sides, because it can cause septal perforation. Right, so that's it about silver nitrate cauterization. Silver nitrate used to be in the olden days used for development of photographs, but right now it has got a use in cauterization and treatment of epistaxis. Now, electrocauterization, again, this is a surgical procedure which is done by ENT under general anesthetic, which uses a diathermy probe, and it's normally done in children who have recurrent epistaxis that's not amenable to treatment. Now, at this point, I would like to also mention that in children, it's difficult to use, let me go back to this slide. It's difficult to use silver nitrate cauterization because this is a little bit unpleasant, even to the adults. It's quite unpleasant. So the youngest patient I've cauterized myself was 10 when I was doing ENT. Anything less than 10, probably you'll be pushing your luck too far. If the epistaxis is recalcitrant to treatment, is not amenable to treatment in any, you have to refer to ENT. Right, so the types of packing that we use are either absorbable, like I said, the nasal pore, or non-absorbable. And the types of packing used are determined by habit, inherited practice, and department or provision. So you might actually walk into the department and say, well, I'm looking for this to pack the nose and so on. It might not be available because it just depends on what the department actually is okay with ordering. So don't stress about it. But you should not get to the point where you cannot get packing material, because that's really a question of patient safety now, which is being compromised. Now, so like I said, the non-absorbable packs are Merocell and Rapid Rhino, and the absorbable packs are nasal pore. That's how the nasal pore looks like. The good thing about nasal pore is that you can cut it in half, because not everyone's nose is as long as that nasal pore. So you can actually cut it in half and actually use it to pack just one side and leave the other one in the fridge. They are normally kept in the fridge. I don't know for what reason. I think they are the material that makes them is polyvinyl alcohol. So I think it needs stability at about 4 degrees. Right, Merosol packing. This is a compressed polymer. So you can actually see it's sponge-like in form. So you need to moisten it a little bit shortly before you pack the patient. And you can see in diagram A there, this is actually going in the inferior turbinate. It's not a superior turbinate, because superior turbinate, you've got a problem with the ethmoid bone there. You don't want to push that into the brain. So it has to be in the inferior turbinate. And then you angle it rightly, and then you push it. It's just to have a string, because you don't want this thing to go very, very far and it ends up in the posterior nasal space. So just got to have a string where you can secure it. Now, the unfortunate thing about the Merocell packing is that you have no control over its volume, unlike the Rapid Rhino, which I will explain in the next slide. So where Merocell packing, you are just dependent on the moisture content of the mucosa. That allows it to fill up and tamponade the bleeding point. Right. So Rapid Rhino packing, well, I would think Rapid Rhino packing would probably consider the third tier approach. So you have to soak the Rapid Rhino pack in normal saline, and then immediately. Now this is the posterior treatment of posterior epistaxis. So you can see that this has got 2 inflatable ends, right? Now, so you inflate the posterior bit first, followed by the anterior end, with, to be reasonable, something like 2 cubic centimeters to 3 cubic centimeters of air, and the patient will be really telling you that they're in a lot of pain as you pump in that little volume of air. And you can actually wait and stand by and see if the bleeding has stopped. If it has not stopped, so you can add another cubic centimeter of air to inflate it, and then it fills up, and then you secure it around the cheek, right? That is how it is supposed to look like at the end of your packing, right? Now, that's the right way on the left side. That's the wrong way on the right hand side, because you can see the packs are already coming out. So you need to make sure that the packs are right in the nostril and they don't come out like on the right side. Now, when I was in Scotland, there used to be something what we call a bolster. So when you've packed your nose like on the left on the left side here, if you put a bolster that comes here, that will be even more ideal, because the bolster should come. Now, this is not a neat bolster, but it should come like this. And to actually allow you to assess while this patient is waiting to be transported to Doncaster. If you are in Bassett Law, it will assess you whether, allow you to see if this bleeding is actually stopped because of application of this nasal packing or rapid rhino. So that bolster, you keep on checking, you go after some time to go and see if it is dripping through or sipping through. And that will actually help you to assess. It can also allow the patient to have probably a sip of water, but you always encourage them to breathe through their mouth, because the nasal passage, as you can see, is closed by virtue of the packing itself. So they've got to breathe through their mouth. So once the patient has been taken from the from A&E onto the ENT ward, what will happen is that after 24 hours, the packs are going to be removed. So they'll be taken to the examination room, where a third speculum, it's a small speculum that we use, or probably in conjunction with a Zeiss microscope, and you look at the litmus area, and if a bleeding point is found, you cauterize with silver nitrate and discharge this patient home with Naseptin cream, with which will be a three to 5 day supply of that cream that they apply twice a day or 3 times a day. Now, those who have recurrent epistaxis and don't settle, they can actually have balloon tamponade done, in which you put a Foley's catheter and dilate, the turbinates, to tamponade the bleeding point. Or if that balloon mechanism doesn't work, you can actually keep these patients in and do sphenopalatine artery ligation or embolization. There is another complication of what we call traumatic epistaxis. And this is one thing you should be able to recognize in A&E, and it's called a septal hematoma. Now, septal hematoma occurs when there's a bleed between the crus of the anterior part of the nose, this is cartilage, and the perichondrium. So blood leaks into that because of either a traumatic event, and it accumulates. Now, the final product of that septal hematoma, which is bilateral, is something that appears like they've got beans or something stuck in the anterior. So it's usually bilateral. You see this nasal cavity actually closed by what appears like seed-like or beans-like structures in the anterior aspect of it. You have got to see it on both sides of the nostrils. And once you've seen that, if a patient is coming to A&E with traumatic epistaxis, please make sure you don't discharge this patient. Call ENT, refer to ENT, because if you don't do this, this patient's nose is going to collapse, and they're also going to get sepsis that could spread through the cavernous sinus. So septal hematoma is an ENT image, and you should be able to recognize it. Traumatic epistaxis, please don't send the patient home if the bleeding is settled. Make sure that they've got ENT review. Also, at most, they might need a CT as well, because there was one case in the country where a patient was sent with traumatic epistaxis. The A&E thought the bleeding has settled. Patient went home, started bleeding, and they died. So those are the dangers of dealing with traumatic epistaxis. Now, septal hematoma drainage, like I said, is done in theater. It involves, and it's done under general anesthetic, and it actually involves a scalpel actually going to dissect that hematoma. Balloon packing, this is quite a very unpleasant because that ribbon there, which is called beep packing, it smells badly and it's about 30 centimeters. Imagine putting that inside the nose. But that is normally done on the ENT ward, but you can actually see how stressful this situation will be to the person who is putting the beep pack and also the patient. That's it. Was the end of my presentation, guys. Thank you.
Thank you, Patrick.
Thank you, boss. Yeah. Are there any questions I could entertain?
Yeah, I think it was a nice presentation, Patrick. Yeah,
Thank you, boss.
epistaxis is quite common, is it? And you know, I think you know, a cauterization. I agree with Patrick that you have to be careful, don't cauterize on the both side. But there's a little bit, you know, also warn people because sometime if the cautery is close to the tip, so they have a gray sort of discoloration of the nose. That's not a permanent. You know, so sometimes people come, oh, doctor, my skin is burnt or whatever. So, so to tell them that you might get a bit of discoloration, but it will go away within 48, 72 hours.
Okay.
Other thing is when we look at the nose, if it is uniformly red and the bleeding has stopped, then probably Nizeptin cream something would work. But if there's a punctate sort of bleeder there, so then they can be cauterized quite easily as a good source of light and spray with xylocaine, 4% xylocaine spray, make it numb, as Patrick is saying, is can be quite uncomfortable sensation in the nose because it burns, silver nitrate does burn the tissues. So then you can just touch the silver nitrate on them sort of points which are the punctate sort of bleeder there. So that's quite effective. It can avoid wait in the department and the ENT admission and talking to ENT, and then they come after 2 hours, 3 hours, sometimes 6 hours nowadays. So yeah, it's also a good skill in ED to do these little procedures, you know. So I think I would encourage, you know, to cauterize that if there's a time there, because patient can be discharged home rather quickly, and the patient service experience is better as well. Yeah, Nizeptin cream, I think it contains peanuts, is it?
Yeah, so you have to, sorry, thank you so much for that. You have to ask whether a patient has got peanut allergy, you know, and before you prescribe Nizeptin cream.
Yeah, I think at this point worth remembering, because the people who are allergic to peanuts, they're rather quite a bit allergic to it. They normally end up having anaphylactic shock and stuff like that. I think the simple set of question, are you allergic to peanuts? As we ask, are you allergic to penicillin? So in case of Nizeptin cream, just add, are you allergic to peanuts? Just a simple, stable question. If they are allergic, then of course we won't prescribe it.
Thanks.
I think I've seen people deteriorating quite quickly, because when there's a bleed, people start panicking, coughing, sneezing, and it get more and more and more and more, and people end up bleeding from the posterior nasal space as well. So it just can be quite frightening and, you know, panic situation. I think.
Yeah, I mean the other problem is people come bleeding, they would have, you know, saturated, you know, towels at home and so forth, and
right,
they're in a status panic state, and you are now telling them that, you know, so if you're like working Bassetlaw, that, no, we're transferring you to DRI, that really just compounds all the stress. The blood pressure will be, you know, going up as well. It's not an easy situation.
Do we have the cauterization stuff or a kit in the department?
Yes, we do. So it's actually normally there's a small box. I will make sure that, you know, I think this is one thing we were trying to discuss with the was it training department, that, you know, we should actually have a visible what is it, kit for emergencies like epistaxis.
I think,
Yeah,
I think, Patrick, this is a very good idea because I can see it in Bradford. I happened to be in Bradford at one time. So they
yeah.
have got this sepsis box. So a box
Mhm.
contain antibiotics and with the sepsis bundle pathway, and all the required stuff is in that little box. So when
Yeah.
sepsis is announced, then they get
Mhm.
that box, everything is inside. I think you can have a bit of epistaxis box because you don't get Xalocan spray. If you get Xalocan spray, there's no applicators. If you get applicator, there's no silver nitrate stick. It's a really quite a bit of stressful situation. I think if
Yeah.
you can do that, it will be really good.
Patrick, I also have a question now. If the bleeding has stopped when we see the patient, is
Yeah.
there still a place to do this silver nitrate thing?
Right. So you're dealing with what brought the patient to A&E. So you
Yeah,
really have to investigate the cause of the bleeding, because it won't go away. It was many. If the bleeding has stopped, you might want to say, well, you do nothing about it. You discharge that patient, 10 minutes out of A&E, they are bleeding again. So you really have to find
yeah,
the source of the bleeding and
yeah.
cauterize it. Yeah.
Okay. So
Yeah.
even if the bleeding has settled, we can cauterize it before discharge, is it?
Yeah, yeah, that's it. And that's where we need to have a kit in A&E to sort out this problem.
Okay.
Because because there are so many cases whereby patient is seen in A&E, bleeding has stopped, they go home and then they come
Yeah,
back again bleeding. Yeah.
yeah. So I have also come across that situation. That's why. Okay, thank you.
Yeah. All right, that's all right.
Patrick, can you stop sharing screen?
Okay, that's fine.
I would like to share something along with what Patrick had just mentioned. It's basically was a nasal bleed that
Yeah.
came in, and basically from the beginning he was rushed into resuscitation. There was quite a lot of bleeding. It was not traumatic, kind of spontaneous onset, and he mentioned to us like, I am being treated for epistaxis. I need particular medication injection, and that's the time only when when my bleeding stops. So we were like, what are you talking about? Because it's the usual way we can actually do either rapid rhino or Merocel and then stop the bleeding. And he was kind of persistent. And
Yeah.
by that time, he was just pinching on the nose and getting. So he said, do we have any documentation or anything like that? They are given a small card. So
Yeah.
to the Royal College of London, basically the hematology department. And I had to
Yeah.
ring them. And this was in Essex. So basically, we had to blue light the medication from UCL to our department and get that. And that medication is called Willet. So WILLATE. So will 8, meaning like, von Willebrand factor plus the 8 is the factor 8.
All right. Okay.
So
All right.
yeah, so both of them needed to be supplemented. Otherwise, he would not have stopped the bleeding. And by the time we gave it, like in few minutes time, it completely stopped. It was quite a learning experience for me that this happened. It was probably like heavily investigated for what exact reason behind previous epistaxis. That is why it made it a lot simpler.
Yeah.
So it is contrary to our, leaping action onto the epistaxis. We actually watchful observation only. We control the blood pressure, give it a little bit of fluids as well. But it was so horrendous seeing him bleeding in front of you, but you can't even do it.
Oh
But having
goodness
said
me.
that, he was exactly knowing what should be done. So that gives us a good idea about like, okay, next time if it comes up, like someone actually verbalize something like this, we may actually need to accept them, because they're right in their position to say, because they've been diagnosed before. So it was quite an experience for me.
I think Suraj, you're absolutely right. listening to the patient is very important. So just, because we are not doing a vet practice. We are not the vet. We're the doctors, human doctors. So we must listen to the patient. Another thing, I think these sort of special group of patients are already known. If they live locally, they are known to the ENT and the services. And most of them have got direct access to or open access to the departments. But having said that, COVID pandemic have changed everything. So all the dynamic have been changed, all the system has been deranged, and it's a really, a bad situation across all the services in this country. Yeah, I agree with you. Listening to the patient is very important, and I think the general practice is people don't listen, is it? Because without asking people, bringing them to the hospital, and then there's quite a bit of situation going on, really.
Yeah. And like,
I've got one question, Patrick, regarding, I had this similar situation in Bassetlaw like a week ago.
yeah.
There was a lady who actually collapsed in the waiting room because she was so, we later found out that it was vasovagal, but however, she was pale and she fell over. It sounded more like she's had a baseline anemia. And when she came in, she was actually going to the triage room, and that's where she collapsed, just outside the triage room. So we got her into the resource, found out something, but because she was bleeding almost, I just had to resort to right away rapid rhino because there was a lot of things happening rather than waiting for them to have like the Marocell or where is the pack and trying to find out the silver cautery. It was just not possible. Because once the rapid rhino is put in place, we cannot let the patient go home because it has to be seen by ENT in 24 hours, mainly to say that, okay, if someone is sent home and they are not coming back, then there's likely chances of them having a mucosal necrosis.
Yeah.
And the advice given by the ENT SHO was a bit surprising versus I could understand their problem, but the fact that patient was in Bassetlaw, needed to blue lighted to DRI. However, when I spoke to the ENT SHO, they mentioned that they have absolutely no bed space upstairs. They could see the patient with in like, this was night I'm talking about. They were talking about tomorrow morning about 1:30. They have the time. I said, like, I mean, I didn't have a clue regarding how the transfer would happen, where the patient would go, and things like that. So I discussed with the consultant in charge, Imran Ullah. He was a bit upfront in that case, saying that, like, why are you saying that? Just send to DRI. This needs to be sent. And I could understand his point, but I understand her point as well because he could not see the patient early on. So in these cases of dilemma, are we just taking the patient to DRI A&E, making them wait for a while for the ENT to come back and assess, and wherever they find the space or not, or maybe in the clinic at morning, they could see the patient? How does it work? Because clearly having an understanding from the other department, being into such a like difficult situation, how would you go about this? This is more like a situational judgment kind of situation for me.
Yeah, right. So I mean, I think the one thing you've got to pick up from this narrative is you don't want to wake up with a dead patient on your side. You'd rather have a live patient. So you need to protect this patient. In most situations, I've been dealing with ENT SHOs, whether they will be like early on in their rotation, they don't know the protocols. I'm not so sure, but they advise you to hold on to the patient, or they just tell you there are no beds, kind of thing. Executive decisions at the level of SHO being done like that, I think it's not acceptable. So what I normally do is, in your case, in Bassetlaw, speak to your senior, and I circumvent that problem by speaking to the ENT registrar. And I always like say, well, I've done ENT myself. Of course, some people would not have done it, but they say this is not right. This patient needs to come to DRI. And the registrar would actually say, can you tell the SHO to accept the patient? Because many a time it's just that SHO probably who is lazy or is not familiar with the protocols, and they're just, you know, affecting a patient who badly needs an ENT bed like that. It's just not acceptable.
Yeah, so basically, I take home the point that res is supposed to be believed rather than SHO, but I asked for the switch to ring to the ENT on call, so they put me to the SHO. Okay, I got your point, sir.
If you ask, you want to speak to Reg specifically because you're not getting anywhere with the SHO, the switchboard can allow to do that.
So this patient collapsed with bleed or what? Was a hypovolemic?
In terms of the rapid rhino you mentioned earlier.
Yeah.
No, not really. She was having an actual bleed to start with. She came in like she was on aspirin like a week ago, and then also she had a bleed at the time. So she was supposed to be stopping the aspirin, which she did, but even after
Yeah, Suraj, we have lost you.
Hello.
Yeah. Hello?
Yeah. Sorry about that. So it was not actually high blood pressure. It was actually like a controlled blood pressure situation. She already had anemia before. It was prior bleed that she had like a week ago was due to aspirin. So she was advised to hold off aspirin, which she did. So this was probably the same site where she bled last time. That's why she presented.
No, because the general principle is the unstable patients, the transportation of unstable patients is a little bit problem as well, you know. So I think Basila is a lot of problem because what is the distance? There's quite a bit of distance between Doncaster and Basila. I don't know how long it take, you know, if I have to go to Basila, it may take quite, I don't know, 45 minutes or something. So it's quite a bit of distance between these two hospitals as well. And,
I think if you look at the shuttle services, it takes around 25 to 28 minutes. So I believe blue light would not be as faster than that. Maybe like few minutes faster rather than anything, because they have to like park, they have to take the patient out, so that takes a little bit of time as well.
Yeah, the other thing is normally unstable patients are brought to resus. You know, if at Basila there's no treatment, then they are brought to resus, and then you know the ENT are on standby. You know, in fact, any other specialty, they must be on standby when their patient they accept patient from unstable patient from Basila or in fact any other trust. And I think escalation, as Patrick is saying, must have escalation policy if an SHO, because SHOs are junior doctors, they are tired, you know, working, and then the judgment is a bit, you know, clouded when you are tired and naked. So no, I mean, of course, you know, we do ask, oh, what the hell you are doing? But I think if we put ourselves in their shoes when we were SHO, so it's quite tiring job, quite frankly. And, you know, so I think a little bit diplomatic, little bit talking nicely, not confronting. Normally you can do the work done. But if in spite of that is, you know, you face rigidity, so don't argue with the SHO, you know, poorly SHO, because, you know, so just ring the next on-call is a registrar, you know. So even if registrar is not, you know, listening, so I think escalation policy trust says that you can talk to the consultant, and consultant knows about that. They won't mind, you know, they won't mind even you talk. Yeah, so.
And I quite agree with Mr. J's idea of getting a kit because it's very important. I've seen every other trust I've been there, they have a kit. And it's quite important to have the kit because if someone's bleeding for about an hour or so, you don't want to mess around saying that, okay, wipe it out, like keep the, apply the pressure, wait for a certain time, and then we will look into whether we can cauterize or not. And by the time when you search for cauterization, the cauterization is somewhere locked up in one of the cabinets.
Rachel is here, is it?
Okay, I'm gonna stop recording for Patrick's one.